Today I am going to discuss about the ABGs of a patient who was brought in the ICU department in an unconscious state. She Patient is a female patient and she's 48 years old and she had a past history of diabetes mellitus for the last 6 years, for which she was taking tablet Emeril glimepiride, and she's known case of hypertension for almost same number of the years, and she was on the tablet Zestril, 5 milligram OD. She also had acute coronary syndrome 6 to 7 months back, for which she was admitted in the ICU, but she never underwent any workup further. For example, she never had angiography, she never had any procedure regarding her workup, like it was never proceeded further. But yesterday she was brought in ICU department in an unconscious state. And after checking her ABC, airway, breathing, and circulation, her GCS was around like 5. So it was decided to pass endotracheal tube because her conscious level was very low and she was not able to protect her airway. But upon checking her glucose level, it turned out to be 29 milligram per deciliter, which is obviously very low. So she was immediately given 5%, 25% dextrose water, 100 ml. And during the process of being intubated, she regained her conscious level, and we dropped idea of putting her ETT. She became conscious, started talking, and it really shows the importance of checking glucose along with the ABC. Whenever a patient is brought in the emergency department with altered sensorium or drowsiness or unconscious state, her airway, breathing, and circulation should be checked, but there should be an immediate monitoring of her any patient's blood glucose level. So when she was being managed in ICU, it was decided that she better be kept in ICU overnight for monitoring purposes. Otherwise, she was all right. There happened a very strange phenomena that she was over and over again was given glucose, but she was continuously dropping her glucose level after every certain hours. So either she had injected herself with the insulin, which wasn't the case in the history, or because she took tablet Emerald 2 milligram in the morning, and it's a glimepiride, oral hypoglycemic drug. So it wasn't getting out of the body, so there was one chance of it that it is not getting out of the body, and the reason can be that she's diabetic and she's hypertensive for a long time. There may be a problem with her RFTs, renal function test. Kidney function is not probably optimum, so there are chances that the drug is taking more time to get rid of the body. So she was kept there in the ICU, and we had sent the labs, including the renal function test and the arterial blood gases. We got the arterial blood gases earlier than rest of the blood labs, and it was revealed in the arterial blood gases that the pH was 7.3 and PCO2 was 36 and the bicarbonate was 18. So she had a metabolic alkalosis because pH was less than 7.35 and bicarbonate was less than 22, and both of these values indicate that this patient has got a metabolic acidosis. She wasn't unconscious for a long time, so it was neither hypoxia nor any other infection which was causing the problem. So we suspected there may be a derangement of the renal function test. And when the renal function test turned out, it was urea was 52 and the creatinine was 2.2. So the renal functions were clearly compromised, and because the patient was checking taking tablet Emeril 2 milligram, and she was for the last 1 week she wasn't taking food properly, so the drug was staying in the body more than the UL. Her ABGs and blood glucose monitoring helped her regain her health back to the normal, because then it was properly treated. ACE inhibitor was stopped and she was put on insulin, and that helped her regain her better health as compared to the previous days. So this clearly shows the importance of first monitoring blood glucose when a patient is received in emergency department or ICU department. And the second thing, the importance of arterial blood gases, because they can point, the arterial blood gases or the ABGs can point towards any particular direction in order to diagnose a patient very properly. Now, if we look at the ABGs of this patient, we see that her pH is 7.323, which is obviously is less than 7.35. And whenever any patient's pH is less than 7.35, we call it acidosis. When we look at the partial pressure of carbon dioxide, it is 36.3, which falls well within the normal range of 35 to 45 millimeter of mercury. So probably this is not the reason which has caused the pH to come less than 7.35. So we will have to have a look on the bicarbonate. Now here we see the bicarbonate is 18.8. The normal millimole per liter. The normal level of the bicarbonate is 24 to 20, 22 to 26 millimole per liter. If bicarbonate is less than 22 millimole per liter or milliequivalent per liter, we call it acidosis, and if it is more than 26, we call it alkalosis. Here it falls in the category of the acidosis and goes exactly well with the pH. So this is the cause of the pH being less than 7.35. So this is purely a case of metabolic acidosis. When we are to look for the causes of the metabolic acidosis, we have a mnemonic mud pile, where M is the methanol, U is the uremia, D is the diabetic ketoacidosis, P is the paraldehyde ingestion, I is isoniazid ingestion or the intoxications, L is lactic acidosis, E is ethylene glycol ingestion, S is salicylate poisoning. And in our patient, it was the chronic kidney disease or uremia which was causing the problem of metabolic acidosis. So, most of the time, if we get ABGs of any patient in the ER or ICU, obviously those who are not stable patient, then this ABG finding will surely point towards a particular direction in order to make some provisional diagnosis. Based on this ABG's finding, we had her renal function test, suspecting it to be the cause of this metabolic acidosis, and her creatinine turned out to be 2.2. So, in this patient, kidney was not secreting a lot of hydrogen ion, and it was hydrogen ion was not being excreted out of the body, and that hydrogen ion was actually combining with the bicarbonate to make more and more carbonic acid, which was being dissolved into water and carbon dioxide. So as a result, bicarbonate was going down and was causing the metabolic acidosis.